the first piece was relationship. When we first started in PLP, we didn't know who we were, and no one else knew who we were either. And so, and we had no funding certainty, and so we also didn't advertise because we were a little afraid if we advertised and suddenly had lots of clients, we would have no staff to deliver. So it took time for us to establish a foothold and make people understand we're not scary. The reason this program is situated with the AMA as opposed to Alberta Health Services or the college or Alberta Health was the idea was framed on education. That's why it lives in the universities, as opposed to being a piece of regulatory or payer kind of hierarchical kind of work. So relationship was key, working with the docs from the beginning. Identifying the local champions was really important because our facilitators aren't always expert in whatever the group is into. So I would be uncomfortable facilitating an audit and feedback session by myself with a group of orthopedic surgeons, for example, because I'm a neurologist. So finding someone within the group to co-facilitate, socializing the process, so talking to people and having a champion within the group who talks to people, all this groundwork is essential so that in that first piece of the cycle, we're not spending all our time on questioning and skepticism and worry and reacting. So the next piece is around question choice. And when we talk about question choice, we're talking about what are the metrics that are going to come out from that. And I'm going to hand this over to Sean, who's going to talk about that now.
There's some things that are really important when we actually factors that we consider when we're looking at metrics. One, obviously the data needs to be measurable and accessible, right? When we first started doing these projects, when I first came on, groups would often say, yeah, let's do a chart review and let's pull all this qualitative data. And we're like, that sounds fantastic, but we just can't do it. We can't deliver that kind of data to clinicians. And fortunately, you know, part of the reason PLP has been so successful is we practice an environment where we have rich data available to us. Very few other centers across the country have access to the level of data that we have here, and that's actually been one of the things that's allowed us to be successful at PLP. So we have to make sure the data is measurable and accessible. It has to be important to the stakeholders, and this sounds like a minor little comment, but it gets back to that whole discussion before around having a local championship and establishing relationship. If this is conceived or if this is meant to be some other group forcing data to a group of clinicians or creating a project for some nefarious or alternative motives, the clinicians are going to see through that and they're not going to be as engaged. So making sure this is important to the stakeholders, and that doesn't mean you need to review, talk to every single member in the group to make sure they think this is important. But at least from a leadership perspective and from the general group, they need to see the value in this. And I'll be honest, sometimes clinicians don't know what they need to know yet, and they don't know what projects are important for them to all the clinicians, but leadership and some of the local champions often have a good sense of what direction we need to go from this perspective. The other thing it's really helpful if there's a strong evidence base for the question that you're doing, for the project that you're doing. And the reason for this is these are not research projects. If you think of these as primarily knowledge translation, we're saying there is evidence in place to do X, we are doing Y, how do we bridge that gap? Audit and feedback is very ineffective if we're trying to answer a research question. If we say, we don't know what to do, let's see what everyone else is doing and figure out the right thing to do in that situation, all it does is create some apathy in the group because Doc X does this and Doc Y does something differently, and you say, well, you can't actually show that your process is better than my process because there's no evidence to support it. So it's really important that there's a good level of evidence to support what you're doing. If there's a gold standard, I mean, all that much the better. The next point, and especially when we're talking about individual physician level data, and this came up from a question earlier, is as much as possible, there needs to be some actionability by the physician. If this is a process that is at arm's length from the physician, or if it's largely related to another group of clinicians, that's just going to disenfranchise those people in the room and just creates more of a sense of, well, they need to do something differently and I'm actually doing everything I can. So it's really important that we address all these 4 components when we choose a metric. These are Chris's, PLP's expert feedback on design maxims. So Be a minimalist. Try not to overwhelm the reader. We always joke, I think everyone in the office has sent Chris stuff and it comes back looking so vastly different. I joke, I'm like, Chris, can you de-Seanify this? Because we tend to present data in an overly complex way. There's a lot of extraneous cognitive load with the data we present, and that detracts people from the main message. Group the information into to similar topics. That helps sort of people focus on that one idea. Keep a consistent information map. Show the trajectory of where you're going with things, and don't assume your reader's going to know something, or don't let them guess as to what the next steps are. Always be reflective. Try to get people to look at their data in a way that helps them identify what they're trying to work on and where they're trying to improve. So the effective data visualization will actually help you do that most effectively. So one of the things that's very different, I would say, with PLP feedback sessions now versus 5 or 6 years ago is we intentionally build in action planning as part of the feedback session. So unlike traditional CME, which is you come, hear the expert tell you what's to do, we intentionally at our feedback sessions don't come in with solutions to whatever data we're providing clinicians. That doesn't mean we haven't thought about what some of the strategies are going to be, but our experience is, and Lara showed this in that paper, is that the change cues and the discussion that happens within that group often leads to the solutions there. And we can use various projects within our group, whether it's TXA or bronchiolitis, as examples of the clinicians in that group and the other healthcare providers could identify what they needed to do differently. And building in time within that session to have that discussion is extremely powerful because, again, getting to the collaboration point that Heather mentioned, people are going to own this if they came up with the idea and it's relevant to them and it's feasible to them. In summary, I hope we've convinced all of you guys, and you guys have all sort of appreciated how audit feedback is a tool that can be very effective for changing practice, but it's not homogeneous intervention. It can be done very differently and with various degrees of fidelity and various degrees of effectiveness. So what we've talked about today is what can be done to increase the impact of audit feedback. Choosing the right measure is vital and involves very close discussion with the stakeholders and the groups you're working with. It's important to actively engage clinicians in the process. CAFF does this by nature, and the R2C2 model does this by nature, but it's very important for us to remember that this is self-reflective practice. This is about supporting clinicians in improving the quality of care. This is not about us telling another group how to do their practice differently. And then finally, it is very easy to provide people with data. It is very difficult to provide them with information and for them to believe that data or that information is actually trying to achieve of improving the healthcare that we deliver. And the reason it's difficult is it's much easier just to send off an Excel sheet to your group of physicians and check off a box that you're providing them with their metrics. But the reality is that's unlikely to be effective, and if it is effective, it's not going to be as effective as it can be without integrating some of these components. So, you have to acknowledge there are some limitations to what we're doing, but developing this self-reflective process is going to be a key part going forward. The social learning environment has many potential benefits from normalizing people's reaction to data, to normalizing that none of us are perfect in terms of providers. We all have areas that we are doing well. We have areas that we need to improve on. There's also a real benefit to getting a sense of what other people have done in their practice to be effective and what people's ideas are that they can look at moving forward to improve their practice.